Hello, this is Jacob Appel, and this is the lecture for week number 7 of the course on law and bioethics. I've been urged to keep these sessions to 30 to 45 minutes, so this is a very broad topic, but today I'm going to address some of the legal issues related to the definition of death. I'm going to examine the Supreme Court's 3 major cases on end-of-life decision-making. And then for the last few minutes, I'm going to talk about legal issues related to suicide and suicide for those with psychiatric illness, and particularly discuss the law and policies around involuntary admissions of such patients and its legal consequences, because that's an area I personally study. I'm going to begin with the case of Jesse Kuchin. Jesse was a 6-year-old boy being treated for an inoperable and incurable brain tumor at a hospital in Salt Lake City in 2004. He had a series of setbacks in 2004 where his brain herniated, and 2 physicians declared him brain dead, which was the legal definition of death in Utah at the time, with a plan to remove him from the ventilator that was keeping him breathing. His parents, Stephen and Gal, were devout Christians who did not believe in brain death. They went to court to demand that their child be kept on the ventilator until his heart stopped beating, because they believed that death was defined by cardiopulmonary death. This was a real case, and it raised a number of challenging questions, the most basic of which was whether the hospital should be required to honor the Kuchin's family's request. You might ask yourself if it matters that Medicaid was paying to keep the child alive, or if alternatively the Kuchins were able to fund the care for him once he came home. And I will add that in this case, the Kuchins were actually able to get charitable donations that would have allowed them to bring the child home on a ventilator. But let's say they actually can pay for care. Is it permissible for them to opt out of the standard of care, which is brain death? Or is keeping a brain dead child alive, as they see it, for years, some sort of gruesome conduct that our society shouldn't permit? You can compare this to what if the couple wanted to embalm a brain dead child and keep him on display in their living room as a means of showing reverence, sort of like Leng in his tomb or Jeremy Bentham. Is it the same thing or different? And I will remind you that death is not simply a phenomenon that has implications for the child himself, but whether or not you're dead or alive has implications for those around you. So let's say it wasn't a young child, but an older person. If you brought him home or her home in this condition, would you expect him to continue to receive his Social Security, his pension? Let us say collateral relatives sue because they want their inheritances, should they win. In fact, as I note in more detail in the course description and the summary, there's a poem by Alfred Lord Tennyson, the former British poet laureate, called Enoch Arden, which deals with the question of what happens when people are lost or missing and declared dead and then return. It's also the basis of the movie The Return of Martin Guerre. And the key point you want to remember from this is that you can be dead for one purpose, but alive for another purpose. A man in Romania went to Turkey a couple of years ago, was declared dead in Romania because his wife thought he died, and then returned and tried to buy an apartment and get a job, and he couldn't because the courts wouldn't recognize him as alive, and his case went all the way to the Romanian highest court. So death is both a biological phenomenon, but also a sociological phenomenon. The parents were ultimately permitted to take the child home on his own. His heart stopped beating not much long thereafter. And it's worth noting that in many of these cases, there is a limit in how long the body can survive on life support once the brain stops functioning. Most states require children and parents, for that matter, to follow the definition of brain death, but there are exceptions, the most notable one being New Jersey. And there have been a number of other cases, the Muddle-Brodley case in Maryland, for example, that have reached different outcomes in different jurisdictions. But I want to emphasize this is brain death. It's not anencephaly. So if you have no higher brain function, but your brain stem is still functioning, you are considered alive in every state. Hospitals under EMTALA must provide chronic life support for anencephalic infants. Prior to the 1960s, cardiopulmonary death, death of the heart and lungs, was considered the definition of death throughout the Western world. And the challenge wasn't definition. It wasn't defining what it meant to be dead, Rather, it was evidentiary. It was proving that a particular person was dead, whether they'd really stopped breathing, holding a mirror, for example, up to their mouth, and there were high-profile mistakes. So it was being certain the person actually had cardiopulmonary death in the era before imaging that was very challenging. In the 1960s and well into the 1980s, there became a widespread acceptance of brain death. And in 1968, a Harvard committee known as the Ad Hoc Committee issued a paper, The Definition of Irreversible Coma, in which it basically said that death had to include death of the whole brain, including the brainstem. And this was the definition that was adopted by a presidential commission assigned to explore the issue in 1981 and incorporated into what is known as a model statute, a sample law that states can choose to adopt, called the Uniform Determination of Death Act. And the vast majority of states, I believe 39 of them now, including New York State, have adopted whole brain death and the Uniform Determination of Death Act. The result of changes in technology and the rise of ventilators created challenges and very high-profile landmark cases. Probably the most well-known of all is that of Karen Ann Quinlan. She was a New Jersey woman who had an overdose on Valium and alcohol in the context of a very intense, possibly starvation diet. And she ended up in a persistent vegetative state. And her family, her parents were actually very religious Catholics, and they talked to their priest about the matter and decided that Karen, based on what she had told them in the past, would not have wanted to live on a ventilator with no prognosis for recovery. And they asked the hospital to turn off the ventilator, and the hospital refused without a court order. And the case went all the way up to the New Jersey Supreme Court, and the court ruled in the Quinlan's favor, and she was removed from the ventilator. For what it's worth, she actually lived a considerably long time after that. She continued to receive nutrition and hydration because the Quinlan family believed that ventilators were heroic measures that weren't justified, but that nutrition and hydration were normal care. They weren't medical care, and continued to offer it. The key point for us is this was a state law case. The New Jersey Supreme Court decided there was a right to die in New Jersey. It is only binding in New Jersey. It doesn't apply anywhere else. And so the larger question was whether or not there was a federal right to end one's life or turn down care under these circumstances. And the famous case addressing that is that of Nancy Cruzan. Nancy Cruzan was a young woman who was in an automobile accident in Missouri, a state with a very conservative, very restrictive definition of when people could turn down care. And the case went to the Supreme Court with her family wanting to refuse nutrition and hydration, and the state saying that they could not do so. The question in the Cruzan case was how much evidence one needed of a patient's prior wishes for the Constitution, the federal Constitution, to require the state to honor those wishes. And Justice Rehnquist, writing for the majority of the court, said in the absence of an advance directive, when the patient hasn't issued a living will or appointed a healthcare proxy, when it's their family as surrogates making decisions, the state, in this case the state of Missouri, is entitled to require clear and convincing evidence that this is what the patient would have wanted. That clear and convincing evidence could be in writing, it could be verbal, but that is a reasonable standard according to Rehnquist. It's a higher standard than a preponderance of the evidence. It's a lower standard than beyond a reasonable doubt. Missouri could have a lower standard if it wanted to, but the Constitution doesn't require them to. Justice O'Connor agrees with this in large part, but she also notes that if there were a proxy or an advance directive, the case might be decided differently. But then there's a concurring opinion from a different justice, Justice Scalia, who says this is not a constitutional question at all, and you should think back to the earlier cases from the first week about abortion and birth control. He says this is a matter for the legislature, not for the courts. Basically, even according to Scalia, if Nancy Cruzan sat up in bed and said, I don't want this done, state could still insist that she get care, nutrition, and hydration against her will if the majority of the people in Missouri voted through their legislature to make that the law. The next major case occurred 7 years later, and this was Washington versus Glucksberg. And in this case, it was not about turning down care, but rather about ending one's life actively or being assisted by a physician. And this was actually a companion case. There were two cases at the same time, Washington v. Glucksberg and Quill versus Vacco, the first from Washington State and the second from New York State. And the question in the Glucksberg case was whether there was a liberty interest. Remember the liberty interest from the 14th Amendment from week one? Whether there was a liberty interest to end your own life under the 14th Amendment. And the 14th Amendment, to remind you, says that no state shall deprive any person of his life, liberty, or property without due process of law. Justice Rehnquist offers a detailed history of end-of-life decision-making and basically says this is not part of the American tradition. I have added to the resources an article I wrote in response in the Bulletin, The History of Medicine, arguing that he may overstate his case. There actually may be much more of a tradition of aid and dying in the U.S. than he gives us credit for. Justice Stevens, who agrees with the outcome, says, as a blanket rule, there isn't necessarily always a right to die. People may not have a right to suicide under the 14th Amendment, but there may be some cases in which there is a right to die, particularly cases in the extreme, like those with terminal illness, and he doesn't want to pass a blanket rule. The second case, Quill versus Vacco, addressed the same issue but with a different approach. Here, New York State, under its law, allowed people to turn down care they didn't want, but didn't allow people to actively end their own lives if they were terminally ill. And here, the plaintiffs sued not for liberty, but for equality. Using the same amendment but a different part, they emphasized the Equal Protection Clause of the 14th Amendment that says no state shall deny any person within its jurisdiction equal protection of the laws. And they said that turning down care you don't want or ending your own life when you're terminally ill are more similar than different, and the same sets of rules should apply. So if New York State is going to allow people to turn down care, they also have to allow people to end their lives under the circumstances. And I should add, in both cases, Rehnquist wrote for the court rejecting the claims of both litigants. So there is no right to die under the Constitution. That means that states do not have to let people end their lives, but they can let people end their lives. And as a result of legislation in 9 states and a court order in Montana, states now do let people end their own lives, as does the District of Columbia. I believe it's 10 states as of now. And increasingly internationally as well. So assisted suicide is very allowed in various forms in the Netherlands, in Belgium, in Switzerland, in parts of Australia, in Canada, and in parts of Latin America. A related question, and one I'm particularly interested in, is when the states should allow rational suicide. I think most people would agree that suicide due to psychiatric illness, you're psychotic, you're intoxicated, you're so depressed you can't make rational decisions, is problematic, and many people think it should be illegal. But rational suicide, when you're not psychiatrically ill, but ending your life for a compelling reason, is more complicated. So, for example, during World War I, armies had forlorn hope squads, people who would charge into battle knowing that they were not going to survive for their country. The picture in the center is a Vietnamese monk setting himself on fire to protest government policy during the Vietnam War in the early 1960s. And finally, that's Linda Fleming. She was the first woman to end her life in Washington State under the aid and dying law there. She did so legally, but it's worth noting that she was dying of pancreatic cancer at the time. Obviously, if she were not going to die of pancreatic cancer, she would not have chosen to end her life. Her goal was not to die, but rather to control how she died, knowing it was inevitable and a very short-term outcome. I always like to mention my own people and my own heritage when I can, and that is the image of Masada, where Jews, fearful of attack by the Romans, engaged in irrational suicide, homicide, killing each other and their children before killing themselves. I'm not endorsing that. I'm just saying that it's rational in the sense there's no evidence they were mentally ill when they did it. They did it for what they considered to be religious or strategic reasons. The issue I'm particularly interested in is whether people who are mentally ill can also engage in irrational suicide, meaning are there people who want to end their lives because of a mental illness, but also have capacity to make that decision. And right now, to some degree, that is illegal in 3 places in the world: the Netherlands, Belgium, and Switzerland. That being said, it's highly controversial, and there have been heated arguments both among bioethicists and the broader public about whether or not the mentally ill should ever be able to end their own lives. There were 2 such cases in the Netherlands in 2010. By 2015, there were 57 such cases. I urge you all to read a very controversial article that I was interviewed for but not quoted on, The Death Treatment by Rachel Aviv in the New Yorker from about 2015 that addresses a number of these questions. And that on the left is Philip Niche's Sarco Death Machine, which is available by 3D printer and has just recently been legalized in Switzerland. And that raises the complex question of whether or not you should need to be evaluated by a physician to engage in this practice, or whether you should just be able to show up in a pod and end your own life, which even I, as a fairly libertarian psychiatrist, find somewhat problematic. There are two subsets of potential suicides among those with diminished capacity, which is different from those who have full capacity but a history of mental illness. There are those who don't meet the most basic elements of capacity. You're intoxicated, you're psychotic, and there's very little support among mainstream psychiatrists or bioethicists to let those individuals end their own lives before they're either brought back to sobriety or their psychosis is treated. In contrast, there are people who meet some of the elements of capacity, but are thought to lack full capacity either due to personality disorders like borderline personality disorder, extreme anxiety, significant depression, and there's a debate among thinkers as to how impaired one has to be if one is going to allow suicide for the physically ill to allow it for the psychiatrically ill under those circumstances. This gives you a sense, by the way, of the different reasons that people who have psychiatric illness have ended their lives in the Netherlands in the first 4 years of the policy. The majority, you can see, are either depressed or anxious, and the rest are a very random assortment, though I have always been puzzled by the inclusion of kleptomania. It is very hard to understand why somebody would make a rational choice to end their life under those circumstances, but it probably is an interesting case. The two questions I'm most interested in are a different set of questions. One is the patient who says, I've been depressed all of my life. I've tried every treatment available to me. Nothing helps me. Please let me end my own life in a safe, painless way, because obviously I would love to not be depressed and get better. The medicine can't treat me, and I don't want to live like this. That's very different from general medicine. But there's a second case, which is actually the case which I have written about in the past, and which was first legalized in Switzerland. The patient who says, I've had bouts of depression and mania my whole life, but right now I'm not having one. Right now I am stable. I am completely in control of my faculties. I passed every capacity test, but I don't want to go through that again. For me, that's the kind of suffering analogous to somebody suffering with a terminal illness or cancer. So please let me end my life now in a safe, painless way before I go through such an experience. And you might add, whether it matters, this person has been going through this for 30 years or 50 years. Maybe somebody with their first bout of illness, you'd be reluctant to let do this. But if they're 70 or 80 and they've said they've gone through this their whole life without relief, we might view it differently. Now I want to talk a bit about suicide liability and prevention, not just because of the details of the specific scenario, though I know there are a couple of psychiatry residents in the class this year, and this will be good fodder for them to think about, but also because I think it demonstrates how imposing liability to achieve one purpose may actually have a unintended consequence in other areas. So it's a better policy study than it is a point about suicide liability per se. I feel like I should emphasize this is not a pro-suicide talk. I spend most of my professional life trying to keep people from harming themselves and committing suicide. The argument that I'm going to make in the next couple of slides is that our approaches to suicide prevention may not help those who are suffering from mental illness and may actually raise the suicide rate. I do want to talk a bit about the suicide pandemic, which may shape our thinking, and I put pandemic in quotes because I'm going to interrogate that concept in a second. I want to emphasize I've chosen data from before the pandemic because who can say for certain until we have data in a couple of years whether this still applies during COVID times. But the suicide rate in the US jumped from 2000 to 2016 by about 30%, especially large, by the way, among teenage girls, but went up for women in every age group and for men except those over 75. Clearly increased more rapidly for women than for men. And up until COVID, it was the second leading cause of death for all Americans ages 10 to 34. And this is a slide those of you in psychiatry and maybe in medicine have probably seen that shows the increase in suicide rates among women, and it looks fairly dramatic. And you get the same sense looking from 1999 to present in rural areas, urban areas, and it's really a widespread phenomenon. In fact, the suicide rate has increased in 49 states. The only state where it's decreased is Nevada, which has one of the highest suicide rates at baseline. If you're ever on a game show and the category is suicide, and the question is what city in the United States has the highest suicide rate, the answer is always year after year Nevada, because Las Vegas, Nevada, because they've designed a city in Las Vegas to encourage suicide. for all practical purposes. They have very little mental health care. They have limited social services. They have lots of gambling and substance use. They have a highly transient population, and they have a high level of gun ownership. I do like to point out that the rise in suicide over the last 20 years is, unlike other challenging events in society, largely a phenomenon of white populations. And in case you were curious, firearms, suffocation, and hanging and poisoning remain the leading methods of suicide in the United States, though in New York, we also see a lot of people who are jumping. You may wonder why I'm belaboring all this data on how and why people commit suicide, but I think it's important to understand the facts of the situation before we think about the law that is implicated by it. And it's less important that you know that people are more likely to end their lives at certain times of day than to know that this has been studied to a great deal of specificity. So we know a great deal about time, place, manner, where, when, how people end their lives, which you think would make it easier for us to prevent it from happening. The reality is that the majority of people who end their own lives are not actively engaged in psychiatric care at the time. But now I want to pull back a second to show you broader data, which suggests there may not be a suicide pandemic at all. That if you look at the data over a period of 50 years or 60 years, we are largely where we were 50 or 60 years ago, which suggests this is more a cyclical phenomenon that operates within a particular band than it is an acute crisis in the moment. So, for example, the suicide rate in the United States in 2011 was the same as 1981. And the teenage suicide rate has actually declined substantially from the late 1980s and early 1990s. This gives you another sense of how we really have returned to where we were 60, 70 years ago. And there are peaks and valleys, and they differ based on demographic category, but there is not necessarily the pandemic that you often hear spoken about. Of course, an alternative way of viewing this is to suggest that in the United States, suicide rates have gone up slightly, at least in the last 30, 40 years, while in the rest of the world, they have gone down substantially. So with that background, I'm going to suggest from a legal point of view that legal rules designed out of a fear of suicide, and particularly suicide liability, are harming patients, and there's an argument to be made that they're even killing patients. I always like to show this slide because I always ask the students when I teach what these individuals all have in common. And people are a bit dumbfounded, and I will share with you. So on the left, that's Albert Einstein, maybe the world's smartest man. That's Roger Bannister, who was once the world's fastest man. Helen of Troy, allegedly the world's most beautiful woman. That is Lassie, the most loyal dog. Napoleon, who at one time was the world's most powerful man. And on the bottom left, those are the late Lillian and Leo Appel, who were the world's greatest grandparents. I always like to share a slide with them. I mention all that because what they all have in common is they are all deceased. Death, unfortunately, is the natural course of life, and I think sometimes we forget that when we're designing the law. Because death particularly, and suicide more specifically, is the natural course of some mental illnesses. So you can get a sense of, for example, schizophrenia across societies, across cultures, has a natural death rate of somewhere between 4 and 5% by suicide. And it's very hard to shift these rates in a significant way. Our treatments, both pharmacological and therapy-based, help some of the people some of the time, but they do help people often significantly. But they help people in terms of their symptoms, their mood, their feelings, their engagement with life. They generally are much less effective in shifting the underlying suicide rate. At the same time, thought leaders in psychiatry and in medicine more generally, particularly after the rise of antidepressants and selective serotonin reuptake inhibitors, went around telling people that we had a way to treat not just depression, but suicide. And in essence, these thought leaders drove overconfidence in the field, and the public began to believe that if people end their own lives, it must be the fault of their doctors. I always like to compare it to oncology. Chemotherapy helps some of the people some of the time. In oncology, when a patient dies, the hospital, the doctor, and the surviving family all blame the disease. In psychiatry, or with suicide, all too often we blame the provider. Even though we know that at present, suicide is the course of illness for some patients and that suicide is highly unpredictable. Take a look at this quote from the former mental health commissioner of my state. Suicide represents a worst-case failure in mental health care. We must work to make it a never event in our program, in our system of care. Or a sign in my ER now reads, suicide is a never event in New York State. I suggest to you this is not an approach that leads to a reduction in suicides. Replace the word suicide with cancer and see how illogical that sounds. This is data that is unpublished from a study conducted by Valerie Poor and Tara, which gives you a sense of how people describe their experiences in psychiatric emergency room when they present suicidal. And unfortunately, the data is rather grim, that 6% of people feel heard and understood. And about 6% of people strongly agree that they are heard and understood, compared to 30% that don't. So maybe I'd like to suggest we're doing it the wrong way if our goal is to reduce suicide rates. Liability for outpatient suicide is an extremely new phenomenon. Between 1927 and 1962 in the United States, there were only 15 cases of suicide liability that reached the appellate courts in the entire country. And all of them were for either inpatient suicide, people who killed themselves in the hospital, or patients who eloped from the hospital and then ended their lives, meaning they left without permission of the doctors. The first case of outpatient liability for misdiagnosis of suicide risk in the country occurred in 1978 in California, and the first one in New York State didn't occur until 1982. Lawsuits against psychotherapists doubled between 1985 and 1987 alone. And by 1987, a quarter were for suicides. Now a majority of both suits and successful suits against the psychiatrists are for completed suicides, because the culture has come to view suicide as a failure of the doctor. I always like to say that children fear doctors, adults fear doctor bills, doctors fear lawyers. And there's a critique of psychiatry in the modern era that says we've gone from a profession aimed primarily at making people well to one aimed at keeping them from doing harm or harming themselves, which are very different phenomena. One consequence of this is, since there's already a desperate shortage of mental health providers, I always like to say there are more psychiatrists licensed in my clinic than in all of Wyoming. Psychiatrists, as Alan Schatzberg once said, don't need to look for business. And the result is they can cherry pick their patients, and it becomes harder and harder for higher risk patients with histories of suicide attempts to find providers. In other words, those most in need of care can get the least of it. And I actually wrote an article about this in the New York Post about 10 years ago, for which I will tell you there was enormous pushback, both from my own hospital and more broadly. But I do think that psychiatrists are avoiding treating the patients most in need of care. Now here is the policy punchline. So Coleman and Shallow report that using standard generally accepted predictors, physicians will misidentify 25 potential suicides for every one person who actually kills themselves. As a result, outpatient providers and ER psychiatrists always err on the side of caution. Their mindset is better 99 patients who would not have committed suicide are hospitalized than one person kills themselves. From a liability perspective, this makes perfect sense. From a care perspective, it may actually increase the suicide rate rather than decrease it. How so? Do you remember our discussion of visible victims and invisible victims when we talked about the Oregon health law and how there are individuals who will know they're not getting care, who protest because they're not giving them a liver transplant, people who don't get mammograms and flu shots, who are the invisible victims and we never keep track of? What we don't see among those 99 patients who weren't going to end their lives are those who were hospitalized against their will when it's an over-inclusive policy and they don't need to. And then, scarred by the psychiatric experience or resenting having their rights taken away, don't come back for psychiatric care when they need it, and therefore commit suicide or at higher risk outside the psychiatric system later on. And they're not going to be on anybody's court docket because no doctor is seeing them, so they're not liable, no doctor released them. They just don't show up on our agenda at all. So when I say that a majority of patients who commit suicide are not in psychiatric care, it's very possible that many of those patients were previously in psychiatric care, committed against their will in an over-inclusive manner when they didn't need to be, and were driven out of the psychiatric system. And that is how liability, and particularly fear of liability, may be driving rather than protecting patients who are at high risk. We actually have a liability paradox. Think back to our discussion on the standard of care. If doctors are acting in good faith and trying their best, liability shouldn't decrease suicide. All it will do is lead to an excess of caution or an imperfect fit. Compensation after the fact that rewards families might make them whole to some degree, although with suicide it obviously doesn't. But most families would much rather, a priori, have a lower chance of their loved one becoming an invisible victim and committing suicide than a higher chance of a guaranteed payment after suicide. So it's a poor fit. It's where doctors and patients both may have one common goal, but the liability system sets up a different objective. So I will suggest to you, and this is my only normative lecture of the year, that we might want to explore eliminating outpatient suicide liability. And I've actually written about this extensively elsewhere, and see whether or not it has an impact, and maybe even a positive one, on the number of patients getting necessary psychiatric care. I hope you were able to tolerate my detour into an area of law and medicine that I particularly study on suicide liability. But I do think the summary sheet sums up the cases fairly well, and we will definitely have a Zoom to talk through the cases in more detail, either later this week or next. Thank you so much.